সার্জিক্যাল সলিউশন অফ হার্ট অ্যাটাক। তো প্রত্যেকটা পেশেন্ট হার্ট অ্যাটাক হলেই যে অপারেশন লাগে না, আর কোন পেশেন্টের অপারেশন লাগে এবং অপারেশন যখন দরকার হয় তখন তাকে অপারেশনই করতে হয়, এইটা নিয়ে আজকে আমাদের আলোচনা। ঠিক, তো শুরুতে আমি যেটা বলতে চাই যে হার্টের নিজস্ব একটা ল্যাঙ্গুয়েজ আছে। হার্ট ক্যান টক, it has its own language, and we need to understand that what and how heart talking. So I entered in medical science in 2000 and I passed out in 2015. This 15 years time I spent to learn this heart language and the crying of heart. So if you see the heart development of heart, the heart starts its development from intrauterine life, and the existence of heart activity, rather sound, we can pick up from mother's womb since 4th week of intrauterine life. So after that, heart started beating until death. There is no rest, no waiting, no visiting hours, nothing. Heart acts like a pumping machine throughout the life, and once the heart stops its beating and it even a single beat if missed, then we can understand what is happened. Now what is the role of heart, how it acts, how its function? It's nothing but a machine, pumping machine. It just pump out the blood and maintain our body's circulation. So if you see the hemodynamics of normal heart, we can see the blood, deoxygenated blood from HBC and IVC is come into the right atrium. From the right atrium through the tricuspid valve, it enter into the right ventricle, and from there it comes to the lungs through the pulmonary artery, and after oxygenation it come back to the left side of the heart, that is left atrium, and through the mitral valve it comes into the left ventricle, and again through the aorta it goes into the body. But how heart itself gets the blood from the circulation? It has its own blood circulation, that is the coronary artery, and this coronary artery rising from root of the aorta, it always carries oxygenated blood. And another important thing we need to understand, that every organ gets blood during the systole of the heart except heart itself. It gets blood during the diastole. Okay, now how the coronary artery looks like when we see in the operative field, this heart looks like, and cardiologists see the heart on the screen. They never see the heart by their own eye, so it looks like this coronary artery. There are two coronary arteries, on the left side and another on the right side, and left side coronary artery again divide into circumflex and LAD, right? Now come to the heart disease. Heart disease actually it divided into three parts. One is the coronary artery disease, second one the valvular heart disease, and third one is the congenital heart disease. These are the three broad category of heart disease. If among these three, actually coronary artery disease and valvular heart disease is in the adult life, and most of this disease, almost 90% disease happen in adult population, that is coronary artery disease, and these are the preventable disease. So today our discussion and main target of our discussion is the coronary artery disease that can be preventable. So now what is the burden of coronary artery disease right now? So if you see the normal prevalence of or incidence of coronary artery disease, we can found almost a quarter of mortality is due to coronary artery disease or cardiovascular disease. Among these, almost more than 80% are due to coronary artery disease, right? Now if you compare the global population with the Indian scenario, you can find in 1 lakh population in India, it is almost 272 heart disease are there, coronary artery disease, and in all base population it is 235. Now cardiovascular disease is a major public concern. In last 2 decades, if you see the demography or epidemiology of a heart disease, you can found that epidemiological transition of this heart disease happened in India. What is that? In Indian population, the heart disease appeared more earlier than the Western countries. Second one is the high case fatality rate, and disease is very much aggressive. Third one is the reversal of socio-economic status. As we all know that coronary artery disease usually happen in high socio-economic status group, but nowadays if you go inside the OT, you can see many of our manual labor, even those who are working in the field, they are also attacked by this disease. So these are 3 variants happen particularly in India, and that is very concerned, because if this happen in this trend, then we all are preventive mode in infectious disease, nutrition, all are preventable mechanism from the government program, from the hospital side. There are the, various programs are running, but even with this high prevalent disease, we are not able to control the coronary artery disease itself. So if it happen in this speed, then we can found in 2030 every 4 normal age population we can get 1 cardiac disease patient. Now this is the main scenario of or burden of disease. Now what is the reversal of socio-economic status and how it affects, that is the major concern. Why this happening in low or poor socio-economic status group? Now if you see in practical day-to-day activity or day-to-day practice, you can find that everybody are in hurry and they are all running towards the urbanization, and people are running from village to urban population, right? They are adopting more urban lifestyle, and that is the main cause why disease is aggressive in village population, right? They are not aware of disease and they are maintaining their lifestyle like urban population, and that is why it is aggressive. And if you see, you can find tobacco use are more prevalent in rural population, and they are, although they are producing the fruit or vegetable, but they are very rarely intake their own food, right? And that is why they are more prone to develop cardiac disease. And these frequently do not receive optimal therapy. They are very neglecting and they are not aware of the action of medicine and its role. So they are lacking of this knowledge, and that is why these diseases are progressing among them. And another thing, all our government policy and hospital policy are made towards the urban population only. The very few and little amount of our policy is reaching to the village population. This is my practical experience. So the policy is all made towards the city and confined into the city, and that is why rural population are nowadays are more affecting due to this disease. Now what are the risk factors? The risk factors, if you see, you can find these are the two groups of risk factors, that one is the uncontrollable or non-modifiable, and second one is the modifiable risk factors. Age, sex, family history, race, these cannot be modified. And another is the smoking, cholesterol, high blood pressure, inactivity, physical inactivity, and weight, obese patient, and diabetes. These can be controlled. So these are the modifiable risk factors. Now, type A personality, what is that? The people are always competitive in drive, restless, hostile approach, and sense of urgency and impatience. These people are affecting more than other people by this disease. Now, alcohol. Sometimes we usually think that alcohol is protective, but no. If normal people on human intake 75 gram of or more alcohol per day, this is a definite documented risk factors.
So the protective is for those people who are taking 50 grams.
Yes.
Per day.
Now, heart attack. The pathophysiology of heart process happens. The ultimate end result is the function. The first thing happened, that is what? The loss of elasticity of coronary artery. Particularly arterial system is having this specific physiological property, that is elasticity. Very beginning of this pathophysiological process, the elasticity of the coronary artery is lost because it micro deposit of plaque or calcium along with the other materials that lead to thickening and hardening of the arterial wall. That's the first coronary artery. That it gradually accumulates the plaque or fatty plaque inside the intima, and it gradually progress into the lumen and causing the luminal narrowing. So this is the process of coronary artery. Now presentation. How coronary artery disease present? There are lots of way we can get coronary artery disease patient. The most common is not the usual presentation, but the most devastating and most dangerous presentation is the sudden cardiac arrest. Although it is a rare or very few people, 5 to 10% of people are of this mode of presentation. So why cardiac arrest happen in coronary artery disease? As you all know, with this gentleman, so why sudden cardiac arrest happened? This particular sudden cardiac arrest happened in non-smoker population, and there is no alarming symptoms previously, and usually this happened due to plaque rupture, and most of these people is having left main coronary artery disease. And the most common cause of sudden cardiac arrest is due to the ventricular arrhythmia. Now another mode of presentation, that is the ACS, acute coronary syndrome. It includes three separate entities, that is unstable angina, second one is non-ST elevated MI, and third one is ST elevated MI. Now what is the presentation? The classic presentation of coronary artery disease, that is angina pectoris. What is that? It is a chest pain or discomfort. Usually it is characterized by, it is exertional, it is retrosternal, it is compressive in nature, and it radiates into the arm or jaw, and it is relieved by taking rest or medication sometimes. It may associated with present perspiration and shortness of breath. This is the classic presentation of coronary artery disease. Apart from this angina can be classified into 4 stages. Now apart from that, there might be some atypical presentation, that is a choking sensation. Heart attack may be confused with digestive symptoms as well. Now sometimes heart attack may comes with tooth pain, toothache, and sometimes nothing. Patient is calm and quiet, particularly in diabetes, and there may be silent heart attack, or shortness of breath may happen in diabetic patient. And sometimes patient may have some symptoms like syncope, or sometimes only the ECG findings. So new onset ECG findings is a mode of presentation sometimes may happen. So this is important message, that almost 90% patients, those who require operation, I ask them, they have invariably positive symptoms of acidity. So sometimes acidity may confused with the angina. So this might not be the acidity simple, but it may be the angina class 1. Now asymptomatic patient may be having coronary artery disease or blockage. Sometimes we can found in routine checkup non-cardiac operation like laparoscopic cholecystectomy or some other operation, we routinely do ECG, and then we can found the ECG changes, then refer to cardiologist or specialist, then they found that there is blockage inside the coronary. Another PSC I already told, and this is a ECG finding, new onset ECG findings, that is a important presentation of coronary artery disease. Now angiography, the ultimate and gold standard of diagnosis of coronary artery disease. There are 2 types of angiography. One is CT angiography and another is conventional angiography, as we all do. Now CT angiography is a very limited use, because if there is blockage found in CT angiography, we invariably prescribe conventional angiography for that same patient. So the angiography, normal conventional angiography, is the gold standard of diagnosis. How can we diagnose? The injection is injected inside the coronary artery, and the coronary circulation is delineated and projected in the monitor screen, and we can found the blockage inside the coronary. The percentage of coronary artery, what is that? That is actually the cross-sectional loss of the area. So how much cross-sectional loss is happened, that is calculated by the software from the computer, and it is put it on the report, right? Now treatment. There are 3 modalities of treatment actually we prescribe, that is the only medication, second one is the angioplasty, and third one is the bypass. So which type of medication is applied, that depends actually the pattern of disease, the risk factors within the patient, and definitely the choice of the patient. So only medication, there are 2 polar group, those who have very minute disease, small blockage, single blockage, and 20%, 30% blockage, then nothing to be done, but patient need to continue medication. Another group of patient, those heart is very damaged already, very much damaged, then ejection fraction very low, and coronary anatomy is not graftable, not PTCable, then those patients are prescribed only medication. Now if you see the recommendation, the only 2 groups, those practically operation is not prescribed, that is single vessel disease and non-LED disease. All other groups are actually indication for surgery. Make it very clear, the single artery disease and non-LED, LED even single artery disease is indication of surgery. Now, why we are going to PTCA? Even though patient are indicated for CABG, the patient, most of the patient choose their PTCA as the first procedure, because the basic difference of CABG and PTCA, when CABG is comes in the option, the patient first think whether I will survive or not, I will die after operation. Second thing that comes in mind, that is, I cannot perform my normal duty after operation, and this is very practical, and most of our patients ask this question to us. And third one is the pain, but I think these all are myth, because although every patient, every operation have its pain, but we have lots of medication to relieve pain, so pain is not a problem. Although pain will be there, but patient can tolerate it. And can we perform daily day-to-day work? This is a very important question most of our patient asked. So only patient can be operated by CABG when we ensure that patient will work, patient will do normal day-to-day activity. When we ensure that patient cannot do his normal activity after operation, we should not operate on that patient. Am I clear? As for example, patient is having CVA with left side hemiparesis or hemiplegia. Patient is not able to move, not able to walk. What is the role of CABG now? Understand? So CABG, when we prescribe, when we do, we should ensure that patient will have his or her normal day-to-day activity. Then only we should do CABG. So second question is always asked to us, but it is, I think, it not correct option. First one is death. We cannot tell who will die at which time or at which place. But yes, CABG is a major procedure and it has its own death mortality rate, but everybody will not die. There is a certain percentage that can happen. Now come to the CABG, the story of CABG, history of CABG. In 1962, the first coronary angiography comes to us, and after that we realize or understand the coronary anatomy, and then people think to do bypass surgery. And in 1964, in Soviet Russia, Vasily Kolesov and Michael Debicki in US and Rene Favalaro in Argentina, they are almost simultaneously did the first CABG in the world. Now PTCA come after 10 to 12 years after that. Now primary intention of CABG, before that I am telling you, I already told you that only 10 to 15% of heart attack patient require CABG. Most of our patients do not require CABG. So primary intention, the objective of CABG is complete revascularization. How is the number of lesion, 3 vessel, 4 vessel or 2 vessel disease, all graftable vessels should be grafted. That is the first intention of CABG. Second one, bypass surgery should be durable, because after surgery 6 months later or 1 year later we cannot do repeat surgery. So CABG should be durable. Even after angioplasty stenting, we can do CABG after 6 months or year later. But after CABG, if you see that CABG done and after 6 months later a patient come with again blockage on the conduit or bypass, then it is not a good for surgeon, not for good for the patient. Now it should be acceptable as the pain, as death and quality of life of the patient in respect. So patient should accept the procedure, and we should ensure the survival benefit and there is no repeat revascularization or minimal repeat revascularization. Now surgical option, what are the options we have? The most commonly performed procedure is the off pump coronary artery bypass. The second one is the arrested heart bypass surgery, on pump surgery. And now the important procedure, that is the minimally invasive cardiac surgery, we can do aortic and high times patient simultaneously. So now conduits, the tube which we used for CFBG, that is left internal mammary artery, right internal mammary artery, radial artery, that are the arterial conduits, and venous conduits RSVG from leg. Apart from that, really we can use gastroepiploic artery, splenic artery as well. So most commonly performed procedure is the OPCAP, and most commonly used conduit is the lima-rima and RSVG. Now best surgical solution for heart attack patient, that is lima-rima Y with total arterial revascularization. Why? Because arterial conduit is always better than venous conduit. The two reasons why arterial conduit is better: because arterial conduits have its wall muscular and it can constrict, it can dilate according to the need, and arterial, particularly in mammary artery, it has its own nitric oxide releasing property, and it is a protein vasodilator. As you already all know that stent, drug eluting stent, what they act? Drugs elute release from the stent after deploying the stent, and it keep patent of the stent. And in CFBG, when we use arterial conduit, particularly lima and rima, it continuously release nitric oxide and it causes vasodilatation, and that is why we called mammary artery as a living conduit. On the other hand, venous conduit we dilate during the procedure, injecting the normal saline, and the diameter what we achieved, that will fixed, and it will reduce with time, because when we dilate there will be a micro venous thrombosis or later on, and that is why venous conduit time. That is why then it would be always done to the patient. Now surgeons do not only do operation, they also have their concept regarding the prevention, because after operation disease will progress, disease will grow. If you not able to prevent this growth of disease process, then your bypass will stop, or bypass also will block, and there are lots of new blockage will develop distal to the bypass. So you should also have your own knowledge regarding the prevention, and you should act and to do the preventive procedure and preventive measures. Now strategy to prevention, that is mass population strategy, high risk population strategy, and secondary prevention. Mass population strategy to prevent the development of disease when population is not having the disease. This is a general population mass assay. Suppose the awareness program, public talking, prevention of risk factors, these are the mass population strategy. The high risk population, those people already have diabetes, hypertension, obese, and dyslipidemia. those risk factors already there, but still they have no disease developed. So this category is having high risk category, they need intensive awareness program or advice. The secondary prevention, those who already have disease, already have CABG or PTCA, but still the disease process will progress inside the body, so they also require preventive awareness. So what are minimum requirement? Stop smoking. Even a single smoking can cause injury to the heart. Smokeless tobacco or even digital smoking, that is the instrument that is only nowadays hookah smoking or whatever it is. So any type of smoking that causes injury to the heart, it should be quiet. Second one is food habit. We should understand what food causes injury to the heart, what is protective to the heart. So we should not take the food that engulfs the heart. We should take food that protects our heart, fruits and vegetables. Now the food habit, not only the content or quantity, but also the quality and how much ingredient, fat or carbohydrate or protein, whatever it is, we should have our little bit of knowledge. Diabetic control. कम खाओगे तो ज़्यादा दिन तक जियोगे, ठीक है. This gentleman having diabetes, even with diabetes, after taking insulin, he play in cricket, as you all know. So diabetes is not the problem, but uncontrolled diabetes can create problem. The control of hypertension, again, exercise, physical exercise, no extra salt, regular medication, and BP should be regularly checked. Now control of body weight, again another important measures, we should take care of it. Daily 45 minutes, at least 5 days in a week we should walk, and not only in the field or roadside, we can use our staircase during day-to-day activity, but we should walk. Checkup, yes, your when we are approaching towards the age group, we should check our blood pressure, sugar. Not only that, regular health checkup as we already do in our hospital policy. And heart attack at home, this is a very important message from my side. What to do? As you all know that inside hospital, inside operation theatre, even after stoppage of contraction or beating of heart, we can survive the patient, salvage the patient. But when that patient experience heart attack and cardiac arrest at the roadside or at our home, what to do? There are 3 separate terminology: heart attack, cardiac arrest and heart failure. There are 3 separate entities, 3 are different. We are talking about the heart attack only. Heart attack, what does it mean? We already know blockage of coronary artery disease and manifestation of that. So now when patient is having heart attack with ST elevated MI or non-ST elevated MI or any type of ACS, what to do? Immediate 2 things you should think of this patient. That is, 1, fastest transportation to the cardiac facility hospital, fast. Second one, don't panic and think quietly and give minimum 2 or 3 medicines if available. Then transport. Don't waste time, because every second, every minute is precious, and time is the muscle. How much time is wasted, then that much type of muscle is damaged. So first target is the quickest transportation to the hospital. Second one, the medication if available, nitrates, sorbitrate and antiplatelets. Yes, nowadays these are all medicine available in a remote village, as I already have my experience in that type of patients presentation. Now after that, patient when reached to the hospital, we should assess first, then single ECG can categorize or differentiate two from others, that is ACS have three parts, three set. One is non-STEMI, another is STEMI, and another is unstable angina. So non-STEMI and STEMI will be differentiated only by ECG. ST elevation, ECG positive, bas, heart attack, then go to cath lab. Now non-STEMI and the unstable angina, the only differentiation of these two required TROP-T. If TROP-T positive, then MI, TROP-T negative, angina. Okay, these two important investigation can differentiate three major category. After that, angio done, CFBG or PTCA. Now thank you. Any questions? Now after that, এর পরে আমাদের একটা ইন্টারেস্টিং জিনিস আছে, এটা অ্যাকচুয়ালি একদম এক্সক্লুসিভলি আমার মাথা থেকে বেরোনো, যে এত পড়াশোনা করলাম আমরা, একটু নলেজ গেইন কত